The topic I want to cover today is which anterior lumbar cases am I most comfortable bringing to my ASC? And I think the operative words there built into that question itself are my ASC, because first and foremost, every ASC is going to function differently. So you really have to understand the variables that apply to your particular center, what your capabilities are, what your limitations are, and how that team focus integrates into that. So general rule, best cases in my practice to take to the ASC are the patients that are going to be able to go home within the allotted time. For us, we've chosen to do a 23-hour observation stay for all our patients. So it's going to depend a little bit on how that number fits into your center. But assuming you can do a 23-hour observation stay, I would encourage you to do that out of the gate. The optimal patients that fit into that are single level, low complexity and morbidity, low-grade spine pathology. We've seen tremendous success with lumbar disc replacements. Those patients, again, tend to do remarkably well from a post-op recovery standpoint and definitely fall into that ASC criteria. With lumbar fusions, we'll do up to 2 levels of the low lumbar spine, so L4-5 and L5-S1. And the other thing that we really focus on is using standalone techniques. So we do use standalone devices. It's certainly an option to do percutaneous posterior fixation, but again, consider how is that going to affect that recovery curve for the patient, and is it going to potentially add time, pain, and potentially delay in discharge. And then really, patient selection and collaboration with spine exposure colleagues is critical to ASC case success. You have to do it safely, and you have to do it with minimal complications. And then the last piece is really kind of taking into account what the recovery period looks like, anticipating the things that are going to delay discharge first and foremost, which is typically pain in our experience, but also things that are going to cause someone to represent, and that tends to be ileus. So we're aggressive with bowel regimens and pain regimens as a result. Always make sure, though, more than anything else that you have to be comfortable doing the procedure. Don't push an agenda, and don't push the envelope, particularly in an ASC setting. Be very, very, very conservative, even with what you would consider to be standard for your practice. Really appreciate your time today. Thanks.